Welcome to the Psychiatry and Psychotherapy Podcast, the podcast to help you in your journey towards becoming a wise, empathic, genuine, and connected mental health professional. I'm your host, Dr. David Pewter, a psychiatrist who splits his time practicing psychopharmacology, individual and group psychotherapy, medical director of a day treatment program, medical education research, and teaching residents and medical students. So welcome back to the podcast. Today we are going to be covering the last part of Sensorium. So in the first episode of Sensorium, I covered what basically Sensorium is, that it's your fluctuating total brain capacity. It's sharper in the morning. Maybe it kind of is a little bit in a lull, 2 to 3 in the afternoon. And, that's why a lot of people who are really high functioning people get some good work done in the morning, get their writing done in the morning first thing. And then a lot of cultures take a nap in the afternoon. And then I talked about in that first episode on Sensorium, what are some patients that have come in with really low Sensorium? So people teetering on delirium almost. I remember one patient that came in with kidney failure and, her kidney function, her ability to sort of clean her urine, right? Or clean her blood, clean the toxins out of her body, clean her toxins out of her body by urinating. When that goes down, you have a buildup of toxic metabolites and your sensorium decreases. And that really gives an example of one of the things I'm going to talk about today, which is how to maximize medical treatment for medical issues to optimize sensorium long term. Another topic I'm going to go into is medications. Which medications are the biggest culprits of sensorium, which ones I would definitely want to remove, and which ones maybe don't cause as much sensorium issues. I'm going to be talking about sleep and how sleep can really optimize sensorium, and how, things like obstructive sleep apnea can really cause issues with sensorium long term. And then I'm going to go into some alcohol and some drugs and how those influence the brain for better or worse. And the last thing I'm going to touch on is a kind of a prelude to a future episode, which will be going over how the way that we feel like we have the potential to change our environment and change our situation can actually change our sensorium. So interesting research on how free will and the thought that you have free will can actually change your sensorium. So, why am I interested in this? First of all, once again, I work in a psychiatric practice, which is both outpatient and, partial hospitalization and intensive outpatient program. So I treat people who are, in between hospitalization and outpatient practice. And, where do you send a patient that's too suicidal to really treat once a month as a psychiatrist, or once a week as a therapist, but not ill enough to be in an inpatient psychiatric hospital? And that's kind of what the partial hospitalization does. That's what the intensive outpatient program does after they graduate from the partial program. And in this program, we treat a unique group of people. We treat people with a range of medical issues and psychiatric issues. And so I am really interested in how to optimize brain function, because basically if you have poor sensorium, the psychotherapy is not going to be as effective. Okay? So the psychotherapy is one way to optimize sensorium actually. So just going through the program, we have shown to increase IQ in our adolescent MEND program. And that's because, if you come in and you're super stressed and you have uncontrolled medical issues, and then all of those get optimized and you're sort of the chronic stress in the home gets relieved through good family therapy, then your brain is going to work better. Okay. So then I had an episode on diet and sensorium and how, there are certain foods and certain lifestyle choices that long-term can change brain function. And then in a subsequent episode, I went through studies on exercise and how gaining strength and having cardiovascular endurance can sort of promote long-term brain health. Yeah. All those things help promote brain health. Okay. So today I'm going to touch on medical issues, sleep issues, drug and alcohol issues, and here we go. So first of all, treating medical issues. So for example, diabetes, which is very common in our culture, as people get older, if they have unhealthy lifestyle, they're at increased risk of diabetes. So if people aren't exercising and eating, the typical Western diet and, very, more heavy set and struggle with weight, you are at a higher risk of getting diabetes. And when diabetes is not properly treated, you have increased risk of depression and cognitive issues. So in one study, they showed that they have twice the rate of depression if they have diabetes. If they have diabetes, but they're brought under better control through medications, the depression risk goes down and the cognitive function improves. Your working memory improves. The ability to hold things in your memory, hold numbers, hold where am I going? What am I doing? I'm walking across the house and all of a sudden I forget what I'm looking for. That's the working memory. That improves as diabetes is controlled. And it's interesting, some of the myths that people come in to my clinic with their diabetes. Like one person believed that they would get obese if they properly controlled their diabetes. And I said, I have no idea where you got that, but I can tell you that it's going to be a lot harder to treat your depression, and it's going to be a lot harder to treat your anxiety. And it sounds like you binge on food when you're anxious and depressed. And so let's focus on treating your depression, treating your anxiety, getting your glucose under control, and you're going to feel a lot better. So controlling diabetes. The next one would be hypertension. So hypertension patients without vascular complications had deficits in the speed of cognition, episodic and working memory, and executive function. Even the hypertensive patients that didn't have vascular complications, meaning they didn't have a history of stroke, they didn't have any small strokes in their brain, even these people, when they're uncontrolled, have a higher risk of sensorium issues. And so we want to treat the underlying issues with hypertension when they're present. We want to treat depression and mental health issues if they're there. We want to treat seizure disorders. We want to treat obstructive sleep apnea. So whatever the medical issue, I can almost guarantee you that if it's untreated, you're going to have worse cognitive function. Okay. The next portion, I'm going to touch on medications. So the first thing I do when I look at someone's medications is I think, is there any way I can reduce the amount of medications they're on? And specifically, I look at the more high-risk medications for sensorium issues. So I want to reduce polypharmacy. And one example is if someone is on baclofen and gabapentin, when they're taken together, they cause cognitive effects. When taken alone, they did not in one study. So just by reducing one of these, they can have reduced cognitive effects. And, it could be sedation. It could be they're just not processing as quickly as they used to. They're not enjoying reading as much as they used to. So reducing polypharmacy. Do they really need to be on every medication that they're on? And one of my goals by the end of someone getting out of my treatment program is that I reduce their medications, maybe 3 to 4 medications. And if they've really engaged the psychotherapy, I find it a lot easier to take them off of medications. So the big class of medications that I try to reduce, there's 2 of them, is anticholinergic medications and benzodiazepines. So anticholinergic medications, probably the most commonly understood anticholinergic is Benadryl. So a lot of people take Benadryl for like allergic outbreaks or to sleep at night. And other medications, though, are anticholinergic. So anticholinergic acetylcholine, is something that we want to increase when someone has dementia. Now, it doesn't help that much, but just think about it like, so we're decreasing it with an anticholinergic medication. So on my website, I will put a link to a PDF with the different medications and all of my notes here and citations. But in general, I try to minimize anticholinergic medications. So different ones include amitriptyline, benztropine, Benadryl, diphenhydramine, nortriptyline, olanzapine, paroxetine, quetiapine. So all of these medications have an anticholinergic burden that's very high. And it also depends on the dose. So sometimes I just try to reduce the dose a little bit. If they're on nortriptyline actually, like at lower doses, is not very anticholinergic. But then as you get into higher doses, 50, 100, 150, the anticholinergic burden really increases. Paroxetine is probably the most anticholinergic out of all of the antidepressants. And it's good for social anxiety, but I try to get every one of my patients off of it, especially if they're professionals. It's not a good medication to be on. It can make you feel sedated and tired, and most of my patients who are on it, if you get the history, sometimes they don't even realize it, but when they started taking it, they started gaining some weight, and they got more sedated and had a harder time focusing and concentrating. So anticholinergic medications, a lot of people get put on benztropine if they're on an antipsychotic, and I usually don't do that unless they have severe EPS. For that reason, I don't want to, put the burden of having them on a sedating medication. Now, if someone has to be on the antipsychotic Clozaril, can you give it at night, so they're not as sedated during the day? Now, one of my patients, when he takes it at night, he gets really bad GERD, so I have to give it during the day, and he's gotten used to it at this point. So Clozaril is a great medication for schizophrenia, probably the best, and it doesn't cause any EPS, so I really like it. It's a pain to start someone on because you have to monitor their blood closely, but it's usually that's not the one that I'm taking someone off to optimize their anticholinergics. Okay, so the second class that I really try to get people off of is benzodiazepines. And I'll have patients come into my office asking for benzodiazepines. The only thing that works is Xanax and Klonopin is what they'll tell me. That's all that works. And, it's possible that they're on it for good reason. As an over-enthusiastic resident, I remember taking one patient off of Klonopin, and he came back the next time with severe akathisia. And he was a patient with schizophrenia, and he was put on this medication likely to treat his akathisia. I didn't realize it at the time. But akathisia is a internal and external restlessness from a dopamine blocker. And so he had developed that, and so I put him back on, and he felt a lot better. But why do I try to get people off of this? Benzodiazepines can cause issues with psychomotor speed, memory, processing speed, attention, verbal memory, general intelligence, working memory, verbal reasoning, and the mean effect size for those things across all, across multiple studies and across multiple different types of benzodiazepines is 0.74. So negative 0.74 decrease in those abilities. And you can think about it as like, that's a big change in people's mental functioning. Of note, after tapering people off of chronic benzodiazepine use, there was a significant improvement in sensorium. However, compared to controls and normative data, there was incomplete restoration at 6 months. This is something that I tell people when considering starting them on benzodiazepines, or when they ask me, Dr. Peter, why aren't you going to prescribe this for me? I say, well, because it's going to lower your intellectual abilities, your sensorium, and if you stay on it for multiple years, when you get off of it, it may take a long time to get back to normal, or you may not ever get back to normal. Now, I question what this really means, because scientifically I look at this and I say, well, compared to normal controls, are these normal controls people who have suffered from a significant psychiatric issue? Because we know that just suffering from, significant psychiatric issue, significant chronic stress can influence and hurt the brain. So I don't know if it's fair to compare them to normal controls, but my case of point is I rarely want to put someone on this during the day for chronic long-term use. Sometimes, a short-acting temazepam or something for sleep seems to be of less concern, and I'll put up that citation as well. And I would like to continue to investigate this and try to figure out, how much of a dose is too much, and, but the people who are on it during the day, every day, and it's usually fairly high doses, those people will have significant cognitive effects. And, so when I have a medical student come in, or someone who's high functioning, who's, needing their brain to do what they do, this is not the medication that I think of first and foremost. I'm thinking of other medications that I'll get to lower their anxiety. Okay, so the next medication is zolpidem or Lunesta. Now, zolpidem specifically is a common sleeping medication. If you take it 8 hours prior to driving or cognitive test, it does not cause impairment, whereas if taken 4 hours before, it does. At 2 hours after ingestion, it causes even balance issues. So zolpidem is one of those medications that, they really need to take it, at 9:30 and then have a good 8 hours of sleep after. They can't just take it and then 4 hours later, show up to a meeting and expect to perform at a high level. The other thing I'll say about zolpidem is I've had several patients who take it during the day to take a nap, and that's a horrible idea. One guy who came into a chemical dependency program would literally find himself in another city after taking zolpidem, because he would drive there and he wouldn't realize what he was doing. I have several nightmarish stories about people who have taken zolpidem because they don't quite remember what they're doing while they're doing it. So they don't remember it in the morning. Like, they'll wake up and go to the kitchen, and the kitchen door will be open and a bunch of food will be eaten, and they won't have remembered and that they ate the food. And in this case, I actually believe them that they don't remember. The next medication class is antihistamines. I try to minimize the doses of antihistamines. Antihistamines can be sedating. I try to minimize or take them off of opiates like Vicodin, oxycodone. In one animal study, opiates reduced neurogenesis by 42% in the hippocampal granular cell layer. What this means is that someone with an opiate on board, their brain isn't necessarily going to regenerate, and specifically the part of their brain, the memory areas, will have a lower rate of neurogenesis. One of the big things about opiates is that if someone has severe pain that is untreated, that can also decrease sensorium. So this is kind of like a difficult place, right? It's like you want the minimum amount of opiates so you have optimum sensorium, and it's it's best to try to use alternative medications. And actually, I found that psychotherapy can reduce pain significantly. I have people that I've seen come into a chemical detox program who have been on opiates, and maybe there was one guy in particular. I'll change his story like I do all patients that I tell their stories. But this guy had about 12, 15 back surgeries, and he was on a bunch of opiates, and he was kind of lying in bed most of his days, watching TV, not really wanting to engage with people. And as soon as we got him off of opiates, we detoxed him through Suboxone. He felt so much better. His pain went from like an 8 to a 6 after 2 or 3 weeks, even being off of opiates. So sometimes chronic opiates, and people's pain levels are still very high. I'm not convinced that their pain would be that high if they were off opiates, because I've seen so many stories of that being the case. So you definitely want to consult a physician, with all of these things, by the way. This is medical information. It doesn't replace a physician. But one of my general thoughts is, how do I reduce opiates? So one of the next big culprits that I have for memory and cognitive issues is Topamax. And topiramate Topamax is given for migraines. It's given sometimes for mood stabilization. It is a nice medication in that it can lower your weight. It reduces your food cravings. It can be helpful for binge eating. And at 25, 50 milligrams a day, it usually doesn't cause very many cognitive issues, but it sometimes does. And when people get higher doses up into like the 100, 200, 400, almost always I see cognitive issues with word finding, issues with short-term memory, issues with, doing things that people used to do and using their brain they used to do it. It just doesn't work as well. And so I try to get people off of Topamax wherever possible. If they have chronic migraines, I try to get them in to see a migraine specialist. Can they get Botox for their migraines? Can the psychotherapy help their migraines? Cognitive behavioral therapy has been shown to be helpful for migraines, and my program can really help people decrease the levels of stress that they have and decrease their migraines. So can you treat the underlying issues as much as possible and get them off of this medication? And some people will not have cognitive issues with Topamax. So it's like you always really have to, get a close history and talk to them about what their function was like before and after. Another medication that can cause issues is valproic acid, valproate, Depakote, Depakine, all the same medication. And of note, this medication can cause working memory issues. It can cause decreased brain function. It can cause decreased sensorium. And so I don't put patients on this lightly. If they really need to be on it, if it's a medication that really stabilizes, and maybe they have true bipolar, true seizures, and this is the medication that seems to be the most helpful for them, then by all means. But if someone has schizophrenia and they were put on it in an inpatient psychiatric hospitalization to speed up the rate of recovery, or for whatever reason, I try to get them off of it slowly. If they're on it just for anger and irritability, I may try other medications. Some people are put on it in a hospital for hyperactive delirium, which interestingly, we're talking about how it can decrease sensorium, but acutely it seems to decrease aggression in a delirious patient. So this is where there's a lot of nuance, and having a good doctor to kind of navigate these things is important. So other medications that can cause sensorium issues are carbamazepine and zonisamide. I won't go into that very much, but I'll put the citations there if you're curious. Medications that can cause mild sensorium issues include gabapentin. It doesn't seem to cause cognitive changes, but can cause sedation, especially at high doses. I see a lot of patients who, are on, 600 milligrams, maybe 3 to 4 times a day, And, we'll try to reduce some of those daytime doses when they come into my program so they can get the most benefit out of the program. And over time, we may be able to get them on lower doses because their pain is decreased, so they don't need to be on this medication as much. Gabapentin is usually for like neuropathic pain, but it can also be, it's commonly used and for anxiety and other off-label symptoms as well. So mild sensorium issues, oxycarbamazepine, trileptal, this medication can cause some sedation. It can cause some alpha wave slowing on EKGs. It can cause some sedation, but it's usually not very bad. And so this is, in my mind, a better option than benzodiazepines for reducing anxiety, for treating sort of mood lability. And another medication, trazodone, it can cause mild issues with short-term memory, verbal learning, body sway, muscle endurance. But usually, this is like if the person's taking it during the day. So this is where, you give it at night and most of it wears out by the morning. Now, some people, when they take trazodone for sleep, and trazodone, in my mind, is one of the first medications I give for sleep. So you put them on 50 milligrams and most people do okay and they sleep through the night really well, a lot better. And, if they're getting more restful sleep, it's easier to treat their depression, their anxiety, their chronic stress issues. So I think it's worth acutely to use a medication sometimes to do this. And the problem with trazodone is that there's a certain amount of patients where there's like an initial dip that gets them to sleep, but then they kind of wake up 2-3 in the morning and then they have another dip of sedation, like right at 7 o'clock when they're trying to get up. So with those patients, I tend to either try a lower dose, and if that doesn't work, I'll switch them to a different medication. But trazodone is not a medication you want to give in the morning. So medications without cognitive side effects. So lamotrigine is one of those medications. Lamotrigine, Lamictal, it's used for certain types of seizures. It's used for maybe not like a severe bipolar, but someone who has mood lability issues, someone who has some sort of high anxiety that needs to be treated. Sometimes it treats variants of bipolar, and I think it tends to be good in people with a history of like chronic trauma, and it doesn't cause cognitive issues, so I don't mind it as much. Now, lamotrigine causes a severe skin rash called Stevens-Johnson, and so patients who take it need to start at a low dose, like 25 milligrams. I increase it every 2 weeks, so I go 25 and then 50 and then 100 and then 150 and then 200, and somewhere around 100 to 200 is, the patient will have benefits where they're having lower anxiety and less experiences of stress, but they are maybe not experiencing the sedation that they would in other classes of medications. So I think lamotrigine is a good medication. People need to be warned about the skin rash and be willing to go into an emergency room if they're having the skin rash, or at least, have some way of reaching out quickly. And but in general, I like the medication. It doesn't cause weight gain, and it's good for anxiety. So another medication, Keppra, although 20% complained of somnolence, it doesn't seem to mess with working memory and sensorium issues. Now, I will say, have a concern of Keppra with increasing some psychiatric issues, actually. So this is not a medication I give for psychiatric issues. I don't know any psychiatrists who do, but it's a medication given by neurologists for seizures. And so if you have a patient that you can treat their seizures without causing sensorium issues, that's a win. Another medication that doesn't cause cognitive side effects is propranolol. Propranolol is a beta blocker. Rarely, I'll have some patients complain of sedation. It's a good medication for test anxiety. It's a good medication to reduce anxiety as an alternative to, benzodiazepines and different medications that lower sensorium. And it can also reduce, the occurrence of migraines. So it's kind of prophylactically given for someone with a lot of migraines. So it's a better option in my mind than like Topamax, which can cause a lot of cognitive issues. Okay, so poor sleep can lead to decreased memory encoding, mood issues, worse concentration, driving accidents, and sleep can counteract the effect of chronic stress and allow the body's immune system to regenerate. So we want to set up patterns of rest, which can allow us to have improved cognitive function, sensorium, sort of thriving throughout the day. And so I recommend, limiting caffeine later in the day, limiting electronics before bed. In a future episode, I've been looking into the effects of social media. And in this one study, they found that a lot of kids are accessing social media at night and video games. And it's causing lots of issues with focus and concentration during the day. They probably don't realize how much it's affecting them. If the person has obstructive sleep apnea, this can be a big issue. Getting on a CPAP, it's a mask that helps the person keep their airways open, can be helpful. Obstructive sleep apnea is more common in our culture than we would like due to the obesity epidemic that we're facing. And, people who come in who are obese that don't feel rested, that feel exhausted, that wake up with morning headaches and that snore. And I'll ask them, does your spouse ever comment that you stop breathing at night? Some of them will say no, and I'll say, okay. And I'll have their spouse watch them. That's the cheapest way to do a sleep test. And the spouse will note that they stop breathing. So they'll be snoring and they'll go like this. Wait 20 seconds. Like that. And that is obstructive sleep apnea. So if they have that, weight loss may not fix it. Some people have obstructive sleep apnea and are in great shape, and I know these people. But some people, weight loss will help. It'll help open up the airways in the throat area. And other things that can help are getting on an obstructive sleep apnea machine. This is a machine that is cumbersome to use. And if you're a therapist and you're treating a patient with obstructive sleep apnea and they just will refuse to use their machine, have them come in with it and do some relaxation training with them. I sometimes will do that with patients. And it's something that I'll bring up every time with a patient with obstructive sleep apnea, in my sort of screening for how things are going. Are they using the breathing machine to help them at night? Are they using it? What percentage of the night are they using it? 100%? And do they take naps during the day without it? Because even naps will not be as refreshing if they don't have their airways open. So, sleep issues. I'd like to do a future episode on cognitive behavioral therapy. It's called for sleep. And this is really one of the best ways of long-term help for sleep. It goes over, bad sleep behaviors, good sleep hygiene, but also has some techniques of slowly decreasing the amount of time in bed, increasing the sleep effectiveness. And a lot of people have behavioral issues with sleep. Behavioral as in, they'll drink alcohol, they'll stay up later than they should, they'll watch Netflix, and they'll watch the most exciting stuff on Netflix. And then they'll wonder why they're tossing and turning and not sleeping well. And after 6 hours or 5 hours of sleep, why they don't feel rested. And it's actually really hard to get people like this to get to bed at night at a reasonable hour, to create some restful practices before they go to sleep. Journaling, reading contemplative and relaxing, meaningful books, doing things like that. The other thing with sleep that I'll just throw out right now is sleep associations. So some people have really bad sleep associations, meaning what do they fall asleep doing? So if you fall asleep watching TV, when you wake up in the middle of the night and TV isn't on, in the lighter levels of sleep, you may need TV to actually fall asleep. So I try to get people to create or fall asleep in the same way that they're going to wake up and need to fall asleep in the middle of the night. A good example of this is infants. If they're used to falling asleep on a nipple, then in the middle of the night, they may need, in those lighter levels of sleep, a nipple to fall asleep again. And so if you can get them to fall asleep on their own, then they can usually transition on their own in the middle of the night. Okay, moving on to drugs and alcohol. So the first drug I'm going to talk about is THC. So persistent cannabis use showed greater IQ decline of 6 points and worse neuropsychological tests with greater impairment of executive functioning and processing speed. So there is a problem with attention, memory, learning, verbal IQ in studies where they look at how chronic THC influences the brain, and it seems to be worse in adolescence. This is a big issue. And, how does marijuana influence the brain in a negative capacity? Well, it does. And that's going to be, unpopular for some people to hear. But it's what I think is the closest thing to science and what science is saying. So I have to put it out there. I have to speak truth. And a 6-point decrease in your IQ is, a mild to moderate level of a decrease. And so, acutely, marijuana can do it, but also chronically, marijuana can have a decreased influence on sensorium. Acutely, it shouldn't surprise us that it decreases sensorium. The people who get stoned, their short-term memory is off. And for this reason, when a patient comes into my office and they have memory complaints, but they're a chronic marijuana smoker, until they're willing to get sober, I won't consider even treating them for their ADHD. And I've had several patients get very angry at me for this. Like, oh, why would you not give me a medication for my ADHD, even if I'm smoking? Other psychiatrists have in the past. And I've told them, like, look, I don't know any psychiatrist at my university that would give you, Ritalin or Adderall for your ADHD if you're smoking marijuana. And so you're going to have to get sober. I'm going to have to be able to random urine test you to make sure you remain sober. And if you, break our contract, then I can't prescribe you this controlled substance. And, I've had a couple patients that just kind of walk out and are angry at me for this. And there's not much I can do, but point them to what I know science to say, which is, that working memory, cognitive function, executive functioning, all is impaired by chronic marijuana use. Okay, the next thing is alcohol. Now we know alcohol acutely decreases sensorium. So, 1 to 2 drinks in, you lose the ability to really know how alcohol has influenced your mind. And a lot of people have a little bit of social inhibition in it, and they have a euphoria that comes with that. And it's, pleasurable. And, one thing that I'll say though, is when I was looking at this and trying to just pull out the literature and what the literature says, is it said that 1 to 6 drinks per week has actually shown to reduce the risk of dementia. And I think this is more red wine than anything else. But it also could be associated with the lifestyle of the people who drink, like half a cup of red wine a night. What that kind of lifestyle is probably someone who's resting more and relaxing more. So who knows how much that has to influence it. People who drink more than 14 a night had increased risk of developing long-term dementia. And so in this one cohort study, and I'll put the citation in my website so you can take a look at that. In this one cohort study, they had increased risk of developing dementia greater than 14 drinks per week. So, acutely, we know drinking more than 4 drinks, so that's the 0.08 on the alcohol level. So for every drink of alcohol, it's about 0.02. So 0.08 is 4 drinks. With 4 drinks, you have impaired planning, spatial recognition, memory, attention, and therefore sensorium. And, most people who do that probably don't care that the sensorium is impaired a little bit. But, I think that's why we have the cutoff of 0.08 with the legal limit of driving. Okay, now on to my last point, which is on free will. So they've done these really interesting studies on trying to convince, one group of people, so they have 2 groups of people, one group of people, they'll try to convince them that they don't have free will. So how they do that is they, take this group of people into a room, have them read an article kind of talking about how really we don't have much control over things. We're just a product of our genes and our environment. And inevitably, we don't have control over many decisions that we make, And so the people read these articles and then they subject them to tests. So they compare this group of people with the other group that reads something just completely boring and random. And what they find is that people who have been primed to think that they don't have free will, by primed I mean they just read this thing, those people are more likely to cheat. They're more likely to conform to social norms. They have reduced helping behavior and increased aggression. And they have this thing where they don't slow down after making an error to reevaluate. And so this is where I'm sort of grabbing onto the sensorium thing. And I'll go into this in a future episode in more detail. But basically in this one study, they found that with this group of people who read this thing that argued that they didn't have free will, they would have them, click right or click left, depending on the color, depending on, the instructions. And normally people, when they make a mistake, they'll slow down their speed at which they're responding to these things. But the people, and this post-air slowing is normal. But the post-air slowing was reduced in the no free will group. So the group that were primed to think that they didn't have free will, they didn't slow down anymore. Which means after making a mistake, they just kept going at the same speed. They just kept moving forward. Interestingly, this is also seen without the priming in people with schizophrenia and children with ADHD. They don't slow down, right? So that kind of makes me think that there's a frontal lobe thing going on here, that normally the frontal lobe kicks in and says, whoa, slow down here. Let's try to figure out what we did wrong. Let's try to figure out how we can do this better. But that was weakened when the belief in free will, intentional control, decreases. So they have found that people who don't have this sort of slowing down process are more careless and more impulsive and display more antisocial tendencies. So kind of how this links to psychiatry and psychotherapy is, sometimes we tell our patients, what they're doing is because of their genes, because of their environment, and we may take away some of their responsibility that they may feel. And some people feel too much responsibility. But I think there's a balance between like that and taking away someone's conception that they can make choices and move forward and overcome obstacles. And so one of my thoughts is we have to be mindful of helping people realize that they actually have control and the ability to make decisions, irrespective of their genes and their environment. People can make decisions. So if they remember, if in the groups that were told that they didn't have that capacity, they had, increased likelihood to cheat, increased likelihood to conform to social norms, and had this increased aggression and this sort of decrease in their evaluative functioning. So that comes to the end of this episode on Sensorium and my little series on Sensorium. Now, these are topics that I'll touch in the future. Specifically, I'm going to have on in the future some of the therapists from the program talk about how they help people reduce stress through family therapy and through different means. And I'll also in the future be going through different mental health issues and talking about these medications more and talking about, how it influences the brain. But I kind of wanted to go through a couple of these episodes to give an overview of this, and hopefully that was helpful for you. If it was helpful, I appreciate good reviews. I'm up to about 50 as of recording this, which is encouraging to me. And I also appreciate people reaching out to me on social media, just saying what's up. And, I post, for every episode, I post a picture on Instagram, a post on Twitter. So, throwing up a comment there is a way of letting me know that you appreciated this and had some thoughts. And if you have any questions, throwing them up in the comment section, I'll try to answer it. Now, obviously, there's a lot of this that goes beyond the scope of what I can do without knowing someone's full history. And so this is where you might want to consider getting a full assessment by a psychiatrist or a physician who knows about this kind of stuff. All right, I will leave it there for today, and have a great day.